Selamat datang di gedung Meri Fakultas Kedokteran Universitas Indonesia. Sebagai salah satu universitas berskala internasional, kami memperhatikan keamanan dan keselamatan. Ada beberapa prosedur khusus terkait keadaan darurat dan bencana. Meri adalah kawasan bebas asap rokok. Saat ini, Anda berada di ruang auditorium lantai 3. Toilet berada di samping lift sebelah kanan dan kiri Anda. Dan musola berada di lantai sky. Ruangan ini memiliki 6 pintu darurat, 2 di sebelah kanan dan 4 di sebelah kiri. Harap perhatikan pintu terdekat dengan Anda. Bagi penyandang disabilitas, harap menempati tempat duduk di area yang sudah disediakan. Alat pemadam api ringan terletak di samping lift di sebelah kiri dan kanan ruangan. Alat defibrilator eksternal otomatis tersedia di lantai 1, digunakan apabila terjadi keadaan henti jantung. Jika terjadi kebakaran, maka alarm kebakaran akan berbunyi. Tetap tenang dan ikuti petunjuk berikut. Berikan prioritas pada ibu hamil, lanjut usia, anak kecil, dan bantulah para penyandang disabilitas agar mereka keluar terlebih dahulu. Bagi wanita yang menggunakan sepatu berhak tinggi, lepaskan terlebih dahulu sepatu Anda sebelum menuju titik kumpul. Segera menuju pintu darurat terdekat dari Anda dan keluar dari ruangan ini. Panduan dari safety officer menuju tangga darurat dengan mengikuti petunjuk evakuasi. Jangan menggunakan lift. Jika terjebak asap, tetap mengikuti petunjuk evakuasi dengan merunduk atau merangkak untuk menghindari asap. Jika terjadi bencana gempa bumi, tetap tenang dan siaga sambil tetap berada di dalam ruangan. Berlindunglah dengan cara menunduk di bawah meja. Pastikan tidak ada benda-benda di atas yang dapat menimpa Anda, lalu berjongkok di lantai sambil tetap melindungi kepala Anda. Apabila dirasa gempa telah selesai, segera ikuti petunjuk evakuasi menuju titik kumpul. Tetaplah menunggu di titik kumpul sampai ada perintah berikutnya. Jangan menggunakan lift. Jangan kembali ke ruangan sampai situasi dinyatakan aman oleh safety officer kami. Kawasan Fakultas Kedokteran Universitas Indonesia di Salemba memiliki sistem dan personil keamanan yang bekerja 24 jam. Jika terjadi huru-hara, mohon untuk tidak panik atau meninggalkan ruangan sampai safety officer kami masuk ke dalam ruangan untuk memberi instruksi evakuasi. Jauhi masa huru-hara supaya tidak menjadi sasaran kemarahan. Bila diminta untuk meninggalkan ruangan, biarkan lampu tetap menyala. Matikan semua peralatan yang ada dan bawalah barang-barang berharga Anda. Safety officer akan membantu Anda untuk menuju titik aman yang berada jauh dari tempat kejadian. Jika terdapat korban henti jantung selama aktivitas berlangsung, mintalah pertolongan dari orang sekitar untuk menghubungi tim medis reaksi cepat RSUPN Cipto Mangunkusumo di nomor tertera di atas ini. Kami himbau untuk selalu menghabiskan hidangan yang telah disediakan dan tetap menjaga kebersihan ruangan. Petugas K3 Gedung Meri selalu memiliki catatan jumlah peserta yang berada di dalam gedung dan akan mendata kembali di area evakuasi untuk memastikan semua peserta sudah keluar dari gedung. Demikian informasi keselamatan dari kami. Terima kasih atas perhatian Anda dan selamat beraktivitas.
Cek, 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 cek. Ini satu. Cek, 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 cek. Satu. Cek, cek. Cek, cek. Oh. Cek, cek. Satu.
Check. Ladies and gentlemen, may I have your attention, please? Our event will start shortly, so please find yourself a seat to settle down. We seek your cooperation to fill in the empty chairs in the front row first, so please move forward to the empty chairs. Before we begin, I would like to announce some housekeeping notes. First, please switch your mobile phone to silent mode in order to avoid any interruptions, especially during presentations and discussions. Secondly, we do hope that all participants could stay in this room until the end of today's agenda. And last but not least, The committee have provided some snacks for you, and you can eat the snacks inside this room. Thank you, and we'll begin the event for today. Assalamualaikum warahmatullahi wabarakatuh. A very good afternoon to every one of us in the room. Before we start, I would like to welcome our guests. I would say this is not an afternoon yet, so a very good morning to all of you. I would like to welcome our special guest of the day, the Dean of Faculty of Medicine, Universitas Indonesia, Profesor Dr. Ari Fahrial Syam, SPPD KGEH MMB, the Head of Department of Nutrition, Dr. Nurul Ratnamutu Manikam, MGZ SPGK Consultant, the Head of Clinical Nutrition Specialist, Dr. Diana Sunardi, MGZ SPGK Consultant, the Head of Master of Nutrition Study Program, Dr. Dian Novita Chandra, MGZ. And of course, I would like to welcome today's honorable speakers. The first one being Dr. Eliza Perez, Fransisco from Meri Mediatrix Medical Center, Philippines. Welcome, doctor. And then Prof. Gil Hardy, PhD, FRSC FASPEN from Massey University, New Zealand. Welcome. And of course, Professor Dr. Hamid Jan bin Jan Muhamed, FNSM from Department of Nutrition, School of Health Sciences, University Sains, Malaysia. We are so pleased to have you here. And of course, our warm welcome to all participants of this event who attended here at Meri or with us by live stream. Ladies and gentlemen, my name is Fadila Iswideandra, and today I will be your master of ceremony and be with you throughout this event. On behalf of the organizing committee, consisted of clinical nutrition specialists in collaboration with Nutrition Master Study Program from Nutrition Department, Faculty of Medicine, Universitas Indonesia, we would like to express our gratitude, and it is our privilege to have you with us today. We hope you will find this event to be fruitful and engaging. The committees have lined up for you some agendas on today's guest lecture that is titled Updates on Nutrition. We will set the ball rolling with opening remarks from our Head of Nutrition of Department and the Dean of Faculty of Medicine, Universitas Indonesia. After that, we will then invite this session's moderator and also our guest lecturers of the day. There will be discussion sessions led by the moderator, and at the end of the lecture, we are highly expecting for you to participate by asking questions or sharing your own point of view. For those who tuned in via Zoom or YouTube, you can put your questions in the chat box and the committees will note it up for you. The guest lecture is planned to finish around 11:25 a.m. and it is sure going to be great hours of interactions and learning for today. Honorable ladies and gentlemen, I will now invite the Head of Nutrition Department, Faculty of Medicine, Universitas Indonesia, Dr. Nurul Ratnamutu Manikam, MGZ SPGK Consultant, to give an opening remark. To Dr. Nurul, the floor is yours. Please give applause to our head department.
Okay, good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. To our Dean, Faculty of Medicine, Universitas Indonesia, Professor Dr. Ari Fahrial Syam, thank you for coming today. And of course, for our distinguished speakers and moderators, Mrs. Eliza Perez Fransisco, thank you for coming. Professor Gil Hardy, nice to meet you again. Professor Hamid Jan and Dr. Steffi Sonia, good. Thank you for coming. On behalf of the Department of Nutrition, Faculty of Medicine, Universitas Indonesia, I would welcome our beloved Dean Faculty of Medicine, our distinguished guest lecturer, and also all the participants to the guest lecture with a topic update on nutrition. Today's guest lecture is a part of clinical nutrition residency program and also collaboration with Master of Nutrition program, Faculty Medicine, Universitas Indonesia. This program also to fulfill visiting professor in Universitas Indonesia. And as we'll know, Indonesia is currently still facing problems among nutrition, malnutrition, undernutrition, overnutrition, and also micronutrient deficiency. And today's guest lecture will be an opportunity for all of us to update current evidence and information, especially regarding overnutrition and undernutrition, especially vitamins and its related diseases. And we know that as life becomes much busier, people often cut their meal preparation, skip meal, making tendency to eat ultra processing food. Thus, poor healthy diet is very common among people in these generations. And in the long term of the overweight on obese population increases. Obesity had increased significantly over a decade by from 10.5% in 2007 to 21.8% in 2018 in Indonesia. And interestingly, this increasing number are predominantly in female population. So to tackle this burden, optimum body compositional management and also weight management with interdisciplinary approach to teams should have been done. And also micronutrient deficiency have been turned blindsided due to its silent symptoms. With this guest lecture, I would like to persuade everyone, all of you, to contribute a part of achieve in the goals with the end of the forms malnutrition, especially in Indonesia. Last but not at least, I would like to express my gratitude to all committee members and people who have contributed their heart and soul to make a successful and wonderful event. May today's guest lecture broaden your knowledge, and this may even be fruitful and useful for everyone who presents here. Thank you for your nice attention.
Thank you, Dr. Nurul, for the warm welcome. Next up, we will hear opening remarks from our Dean of Faculty of Medicine Universitas Indonesia, Profesor Dr. Ari Fahrial Syam, SPPD KGEH MMB, to give an opening remark. To Prof. Ari, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, our friends from Philippines, Dr. Eliza, Perez, Fransisco, thank you. And also a friend from New Zealand, Professor Gil Hardy, PhD, from Massey University, Auckland. And also we have Professor Dr. Hamid bin Muhamed, from School of Health and Sciences, USM, University Sains Malaysia, and also Gard, who joined this lecture. And we have Professor Aryono, head of PhD programs for nutrition, and Dr. Nurul, head of department, student, and also staff who joined in this guest lecture updates of nutrition. First of all, I would like to say thank you, warm welcome to all speakers. Thank you for coming and join my little bit tour this morning. I saw that this is we are in the new building of Faculty of Medicine. Start using this building 2017, and then we have the old building in the front of this building. We started using this building 1920. So this is a heritage building, and then please enjoy our building, our Faculty of Medicine here. And yes, I think Dr. Nur mentioned that this is a good chance for our student can discuss with you about the nutritions. And I think, and also I think, because you know that the nutrition is one of the main problems actually, and also we have now problems with the nutrition, especially for overweight patients. So that's why I think this is the important lecture from you to us, to our student, and also for our staff as well. And I hope that after, I mean, not only for giving a lecture, I hope that we can make or build a good collaboration in the future. Yes, I mean, maybe we can make like a student exchange programs, or maybe one time that one or two our academic staff can to take PhD in your institutions. And actually, the committee the committee from Nutri invite me to talk in the Nutri, but because I have a meeting in the so Malaya, so there's I cancel to be a speakers in the Nutri. Actually, I'm a gastroenterologist, so I work in the nutrition area as well, like to help. I mean, to help patient with the malabsorption, and also you know that the IBD patient have problems with the nutrition as well. So yes, so this is my area as well to talk about the nutritions. Again, on behalf of Faculty of Medicine, thank you for all guest speakers from Philippines, from New Zealand, and from Malaysia, and also for our students and for staff as well. And please enjoy my Faculty of Medicine. Don't forget to take photo, and then don't forget to and then send your photo with us in this building as soon as possible in your social media. This is the important thing. And sorry about the Jakarta traffic jam. Please sorry, because this is my hometown. Thank you very much. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ari, for the superb opening. Prof. Ari, we would like to ask you to please come on stage again to deliver the souvenirs to our speakers. And I will now invite Dr. Eliza, Professor Gil, and Professor Hamid to the center of the stage to receive the souvenirs from Faculty of Medicine, Universitas Indonesia. For our speakers, please still stay on the stage because we will do another photo session. Okay, so now let's take a picture together. I would like, sorry, Prof, we need your insights on today's lecture. I will now invite Dr. Nurul, Dr. Diana, Dr. Dian, our moderator, Dr. Steffi. Prof. Haryono to the stage because we're going to do another photo session. Okay, thank you so much to everyone. Please give applause to our Dean and also our speakers of the day. Thank you so much. And last but not least, we still have another photo session with all of our participants. Please just stay seated. And our committee will take the pictures from the front side of the room. For the committee, please stand by at the center of the stage. We would like to do another photo session from the front side of the room. Okay, so everybody please prepare your best smiles because best believe your smile will be seen from the camera. Okay, everybody, are you ready? On three, everybody smile. 1, 2, 3. Okay, another one. 1, 2, 3. One more from that side of the room. This is a big room, so please be patient. 1, 2, 3. Okay, thank you so much. This is the end of our photo session. And honorable participants of the day, we would like now to kick off our main event for today. Without further ado, let's start the main agenda. I will introduce to you our moderator of the day. Our moderator completed her professional education as a clinical nutrition specialist at Universitas Indonesia. She is a civil servant who's currently serving as clinical lecturer at Faculty of Medicine, Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital. She is the Academic Quality Assurance Team in Specialist Medical Education Program, Clinical Nutrition Study Program at this university. In addition, she is also a functional staff at Dr. Cipto Mangunkusumo Hospital and also Primaya Evasari Hospital. She has published several articles, mainly focusing on clinical nutrition in national and international journals. Please give a big welcome to Dr. Steffi Sonia, MGZ, SPGK Consultant.
Thank you, Dea, for the introduction. Good morning, ladies and gentlemen. My name is Steffi Sonia, and I will be serving as your moderator for today. Let me inform you of a brief rundown of this guest lecture. In the first, we will have 2 sessions of presentations today. And in the first session, there will be 1 presentation from Dr. Eliza for about 25 minutes, which will be directly followed by a question and answer session for 10 minutes. In the second session, there will be 2 presentations from Professor Gil and Professor Hamid for 30 minutes each, and there will be a question and answer session for 45 minutes, followed by conclusion. So now, moving along to the first session, I would like to welcome the first speaker, Dr. Eliza, to deliver her presentation on the topic Interdisciplinary Team Approach to Weight Management. Dr. Eliza May Perez Fransisco is a medical doctor and a nutrition support consultant at Asian Hospital and Medical Center Philippines, St. Luke's Medical Center Philippines, Meri Mediatrix Medical Center Philippines. She is the head of Nutrition Support Team and Weight Management Center, Meri Mediatrix Medical Center, and also the chairwoman of Occupational and Family Medicine Department, Asian Hospital and Medical Center. She specializes in occupational and family medicine with a subspecialty in medical nutrition. She is also a peer reviewer of Clinical Nutrition Journal of FASPEN and chairwoman of International Clinical Nutrition Section of FASPEN. All right, Dr. Eliza, the floor is yours.
Good morning, everyone. Thank you to the organizers for inviting me today. Dr. Ari, and Dr. Diana, Dr. Steffi, and to all the LOs for taking good care of us. So today I'm going to talk about the interdisciplinary approach to weight management. So first off, I just want to ask, who among you handles weight management patients? Do you take care of patients who are overweight and obese? And does anyone here work in a weight management center? And is there a center here in the university or in the hospital? Okay, so hopefully the things that I will discuss today will be useful and practical to the students and to the clinicians in the audience. Next slide. Okay, so this will be the outline of my talk today. And I'm going to go briefly through the roles of the, can I move? So I will define the roles of the different team members. And then I'm going to briefly discuss the algorithm of weight management and then to present local experience in the Philippines. I'm looking for the one who's controlling the slides. Who's controlling the slides? Okay, so next slide, please. Okay. Okay, so we all know that obesity is a metabolic disease and it has reached epidemic proportions. And worldwide, we have 1.9 billion overweight patients, and this was as of 2020, and 650 million obese patients. Next slide. In the Philippines, next click, we have 117 million population, and out of this, 38.6% from the ages of 20 to 59 are obese. And this one, next click. Okay, and this equates to 45 million Filipinos who are overweight and obese. Next slide. So first off, what are the roles of each member of the interdisciplinary weight management team? Next. Okay, we'll start with the physician, the doctor. So we as physicians address the issue of weight loss. We're often seen as the best source of health information for the patients. We can give advice to the patients, and this can help increase motivation of these patients. However, a lot of us physicians are unaware of how to approach the subject of weight. And we need you as doctors to encourage the patients to adhere to the medical advice and to view obesity not as an aesthetic thing, but as a significant but treatable health concern. Next slide. We go to the registered dietitian. Do we have, in Indonesia, I understand you don't have dietitians. Everyone is physician. Do you have dietitians who are master graduates of BS Nutrition, or they became doctors first? Doctors first. Are there also dietitians? Oh, okay. So in our country, we also have dietitians who finished bachelors in nutrition and dietetics. So you should lay the foundation for dietary change and guide the patient towards simple, effective strategies so that they can improve their diet quality and decrease the overall energy intake. And we have to remember that effective weight loss education should include not only strategies to eat less, but also to eat healthier, eat better. Next slide. We go to the exercise specialist. So our colleagues in rehab and physical therapy help integrate physical activity into a healthy lifestyle. And we all know that physical activity is an important aspect of any weight loss regimen or treatment. And it is the combination of diet and exercise, which is the most effective behavioral approach to obesity treatment, better than either one alone. Again, the specialist should try to work on small achievable goals and encourage the patient not to lose weight really fast, but just small goals that can be reached. We have tools that can be used, for example, pedometers. Nowadays, we have iWatch or fitness watches, and these can be used to increase the physical activity of these patients. Next slide. We have behavioral therapists in our team. In some teams, we have psychiatrists because we don't have psychologists in some hospitals. In another hospital, in the weight management center where I work, we have occupational therapists who are also behavioral therapists. And in another hospital, because I work in 3 hospitals with weight management centers. The third one, we have psychologists. So these colleagues are in charge of mentally preparing the patient. We know that behavioral therapy provides mental preparation and structure so that these patients can overcome their obstacles and barriers and identify and achieve their goals. So again, small steps, feasible and achievable goals. Next step, next slide. The nurse. So the nurse keeps the patient involved, and in the team, the nurse is the key patient contact and like the middle or the nexus for communication between the different team members. So the nurse has a unique position because he or she is able to educate the patients, make them more comfortable and accepted, and to help gain access to the kind of information, or provide information that will help direct the optimal treatment strategies to these patients. Next slide. So this interdisciplinary approach is helpful in letting patients meet and overcome the challenges of lifestyle change and to succeed at weight management or weight loss. So all these skills all come to fore or are brought together by the different team members, and this is essential and needed for long-term commitment, and also clear and frequent communication is important in the team. So next slide, we will go to next click, the algorithm for obesity, for the medical care of obesity. So I'm sharing some artwork that are related. So we had the fat Mona Lisa earlier, and now we have Michelangelo with a higher BMI. Next slide. So this is these are the steps in managing obesity or overweight. Of course, even in nutrition, we start with screening and assessment or the diagnosis. And then we formulate our treatment goals and treatment plan. And then, of course, we monitor and follow up the patient. Next slide. So for screening, of course, it's important to have the height and weight so that we can compute for the BMI. And for the WHO standards, a BMI of greater than 25 is considered overweight. In the Philippines, we use the Asia Pacific. I'm not sure here in Indonesia, do you use WHO or Asia Pacific? For Asia Pacific, it's already obese for 25. And we also check for the presence of weight-related disease or complications. So not only the BMI, you also check the history for conditions that are associated with overweight and obesity. Next slide. So when we assess patients, of course, we have to have a good history. We conduct a complete physical exam. We can have or order diagnostics or laboratory tests. And then we review the systems. So we have this in our chart so that the doctors don't forget to ask these questions. And then we also check for history of previous weight loss attempts. We also check on food preferences, and the last one, previous attempts like diets and was there surgery in the past. Next slide. So for the history, check the family history. Our dietitians help us with the dietary history and food records. Of course, you ask about physical activity and exercise. What are their eating patterns? Do they have stress eating? Do they have night eating or binging? We also go into the psychological aspects. We check anxiety and depression or mood disorders. A lot of our patients have bipolar disorder. Comorbidities like hypothyroidism, smoking. We also ask about smoking habits and if there are attempts to stop smoking. And we also discuss with them the health consequences of obesity. And what's more motivating to the patients is not the external looks, but when we tell them that this is related to risk of hypertension, cirrhosis, diabetes, heart attacks, then they become more motivated to lose weight. Next slide. So I just wanted to share with you, can you click? Okay, for the physical exam, measure height and weight. And of course, this you should use a hospital grade weighing scale. If the patient is more than 350 pounds, we use the platform scale. So we have morbid obese patients. Some of them cannot stand up, so we put them on a wheelchair and we subtract the weight. And then we, of course, take the vital signs, and also bear in mind that we have to have special cuffs. So the ordinary cuffs may not fit on very obese patients. We measure waist circumference and or waist to hip ratio also. And we also do body composition. So we have various machines. Some are handheld, some are standing, and some are also for recumbent patients like this. Next slide. So for the students and the young clinicians here, when you do a physical exam, you need to assess for the presence and impact of obesity-related diseases. So check for other things related to comorbidities like diabetes, hypertension, high lipid levels, cardiovascular and respiratory joint diseases, and liver disease, as well as sleep disorders. And you also look at the back of the neck for acanthosis nigricans, which is a sign of insulin resistance. And you can check also with the laboratories for fasting insulin assay. So next slide. For laboratory workup, these are the suggested tests. So the whole chemistry profile, which includes the sugars, the lipids, uric acid, thyroid function, liver function. And if the patient has other comorbidities, then you also add some laboratories related to that. If there are endocrine problems, then you can check for cortisol. And if you suspect for NAFLD or fatty liver, then you can also request for an ultrasound or a elastography test like a fibroscan. And then if the patient snores and has risk factors for sleep apnea, then you can ask for sleep studies. So we also have a sleep specialist in the team. Next slide. So when you, after screening and assessment, one more click for the slide. For the clinical component of the diagnosis of obesity and overweight, we look at the BMI. We also, but you have to make sure that your BMI is accurate, because you can have a high BMI, but there's a lot of fluid or ascites, and maybe a patient can be highly muscular and heavy, but not really high in fat or adiposity. We check, I mentioned earlier, the waist circumference, and we can also couple this with body composition test. Next slide. So when we assess the patient, I mentioned earlier that you look at the BMI and you correlate it with, so going to the right, I think I'll look at this one. So you look at the BMI, and then you also look at all these factors. And if the patient has any of these comorbidities, then that should trigger you in also checking for the BMI. Okay, so start with the BMI and then check this. Or if you have any of this, then suspect weight-related concerns. Next slide. So when we stage overweight and obesity, the AACE and the Obesity Society have these recommendations. So for normal weight, of course, a BMI less than 25 for WHO, less than 23 for Asian population. Stage 0 is when there are no complications with a higher BMI. Stage 1 is when there's one or more complications. In stage 2, when there's at least one complication, and you need more aggressive weight loss for these patients, okay? So stage 0, 1, 2. Next slide. So for the treatment goals and considerations, next slide. How do we plan and treat obesity and overweight? Next slide. So we have 3 levels of treatment and prevention and treatment. So primary, you want to prevent overweight and obesity, and you can do this through a healthy meal plan, physical activity, health education, and modifying the environment. We call it a built environment. For secondary prevention, there's already overweight and obesity, so you want to prevent the progressive weight gain, and you also want to prevent complications. So again, lifestyle therapy, which is diet and exercise, and you can consider pharmacotherapy if the lifestyle changes are not effective. Now for tertiary, you want to achieve weight loss, which is enough to lessen the complications and to prevent further deterioration. So again, lifestyle. So the cornerstone is really lifestyle and behavioral therapy. And then for this, you add pharmacotherapy. For the stage 2, lifestyle, plus you can have pharmacotherapy, plus if for higher BMIs with comorbidities, maybe bariatric surgery. If no comorbidities with a BMI of 40 and above, bariatric surgery. Next slide. So when do you initiate weight loss medications, and when do we consider bariatric surgery? Next slide. So For pharmacotherapy, this may be instituted with a BMI of 25 with the latest guidelines. For when the BMI is 27 with comorbidities or greater than 30, then the patient is already a candidate for bariatric procedures and pharmacotherapy. And of course, all of them are candidates for diet, exercise, and behavioral modifications. Higher comorbidities, again, bariatric surgery. In our institution, we already have patients with BMIs of 30 with comorbidities, and they already undergo bariatric surgery, ranging from some still have balloons now, intragastric balloons. We don't do lap bands anymore. It's more of sleeve gastrectomy, and some patients have the bypass, but it's not so popular back home because it's more, it has more complications and it's more invasive in a sense. Next slide. So for follow-up, once you hit the plateau, you need to re-monitor or evaluate the patient for weight-related complications. And if these have not been treated, then you need to intensify the weight loss therapy, and you need to use other complication-specific interventions. So we all know that obesity is a chronic disease, and the levels or the stages are not static. Patients can change from one stage to the other. So therefore, we need always to follow up the patients, reevaluate, and look at long-term treatment. Next slide. So lastly, I'm going to present local experience in our different weight management centers. Next slide. So this is our weight management center in one hospital. This is south of the capital, Manila. And we've had this for close to 15 years now. And this is our team. And I wanted to share that within the team, every so often, they check the BMI. We have a weight, we monitor ourselves. And because it's not allowed that we have models who don't speak the talk. So we can't have someone telling you, you lose weight, Dr. Hardy, and the patient's big. So we have to set a good example. And the consequences, if the patient has a low BMI or a high BMI, we ask them to treat us to pizza. No, I think the consequence is, I think they have to pay to the team. Like, this is an amount which we will use for our Christmas party. So next slide. This is the reception area. We have a complex. So our management, the hospital management, gave us a nice area that has consultation rooms, the area for dietary advice with the pyramid. We have a gym, the next slide. That's our gym, which is next door, so that patients will come for diet and exercise. Okay, and the gym has trainers or physical therapists. Next slide. And we use certain tools. I mentioned the platform scale. We also have a weight fat vest, which looks like an adipose tissue. It's like a rubbery belt, which we ask patients to wear, and it weighs 20 pounds, around less than 10 kilos. And it's not for weight loss. It's just for them to wear it and feel how it is to be that heavy. And also those who already lost weight, let's say a patient lost already 10 kilos, we ask them to wear it again and say, see, this is how you were before. And now you've shed that extra weight. And then this is our Tanita, body composition, body fat analyzer. Next slide. And we have these advertising models that go around the hospital. We've had them for 15 years. So we show this to the people in the hospital to remind them about the being skinny or being overweight and obese. Next slide. And I just wanted to go briefly through some packages that we have. So when we first see the patient, there's a doctor that sees this, a weight management center physician, and we do fat analysis. Then we ask for a battery of tests. Next. And in the intensive phase, we bring in a multidisciplinary, multi-specialty team. So we have endocrinologists, dietitian, cardio, to give clearance for the exercise, psychiatrist, rehab doctor, and physical therapist. And in the maintenance phase, very similar to this, but we repeat the body fat analysis. Next slide.
Sorry, Dr. Eliza, time is about 3 minutes left.
Okay. 3 minutes to go or finished?
3 minutes left.
Left, okay. And then we have pediatric. So not only adults, we also have a pediatric team. And some of us are family medicine, so we handle both adult and pedia. Next slide. And for the dietary counseling, we just made these 4 sessions to spread it out so that the patients don't feel overwhelmed that everything is told to them in one session. So they do a food recall, food frequency, they talk about body composition. And then on the second session, that's when the patient is given a meal plan and discuss the food exchange list. On the third, they start talking about fad diets, explanation of other obesogenic foods. And then on the fourth, we also teach reading labels and other consequences of being overweight and obese. Next slide. This is just an example of a body composition test. So we have a SECA machine also and a Tanita. Next click. So it shows fat mass, the body composition chart, skeletal mass, visceral adipose tissue, water content, and the REE. Next slide. And I just wanted to share with you other perks that we have in the center, a big toilet so that the patient can fit. I've used it, I almost fell inside. The patient's chair is also big so that they don't feel uncomfortable in the clinic, that they're like, so we have this. And again, this is a more high-tech body composition in another hospital. Next slide. So the tools that we use are food logs or food diary. Sometimes they put it in their MyFitnessPal on their phones. We don't have an indirect calorimetry in the other hospital, but we use resting metabolic rate. Meal replacements like shakes. We have some commercial and internet programs. Some companies deliver food, and we teach with a pyramid, like portion control, and then the dietitians take care of the one-on-one individualized dietary counseling. Next slide. So in summary, weight management is most effective with a team approach. So each member plays a key role. There are guidelines and algorithms that can help us implement this multifaceted care plan. And we have local weight management centers that offer interdisciplinary approach. And these are also directed by international local guidelines. In closing, next slide. I wanted to share another poem with you, care of ChatGPT. So in UI halls, I found a place where knowledge blooms with boundless grace. Diana's invitation, a gift so kind, to speak of weight management entwined. Interdisciplinary paths we explore, a journey of learning forevermore. Gratitude fills this heart of mine for this chance to share and to intertwine. So thank you for your kind attention.
Okay, thank you, Dr. Eliza, for a very informative and interesting presentation. We invite, maybe you can sit here beside me. Okay, so now, ladies and gentlemen, we have come to the question and answer session. For the online participant, both Zoom and YouTube, you can post your question in the chat box. For the offline participant, you can raise your hand and deliver the question by mentioning your name and institution. And you can ask in Bahasa or in English. So please ask the question. Okay, please, Dr. Nur.
Yeah, I'm sorry. I have questions. This is quite frequently asked by medical doctor in our residency program. How about how to manage weight management in night shift? Yeah. Because our residents in this teaching hospital sometimes have a night shift, so it's difficult to weight management because sometimes the body weight become increasing as a program. So do you have any tips or any advice for this condition? Thank you.
Okay, so you mean people who work night shift in the hospital or call center?
The hospital.
Okay, okay. It's similar to back home. We have a lot of BPOs, like offshore companies, and they work with US time. So they're awake the whole night and they're eating to stay awake. So tips in let's say wellness program in our hospital, we have reminders about snacking at night. We don't have in our machine in the floors, like there's food, it's not allowed to have chocolates or soft drinks, soda there. There is a store downstairs where they can buy food, but healthy. They have to be healthy food. The kitchen is cooperative. So those nurses, doctors who stay at night, they also get healthy meals. Cannot, of course, they can buy pizza outside. The guard will not stop them. We don't have programs yet encouraging exercise. We have a recent wellness program where every 4 o'clock, 3 o'clock, they say, wash your hands. 4 o'clock, they say, get up and dance or get up and exercise. But that's 4 p.m. We don't have at night. So I think that's an eye opener that we need to remind people who are on duty late hours of the night to still move, like we have physical activity. Maybe we can open our gym. It's closed also. And then maybe remind them more about weight management. For some of my nurses, I give them shake, meal replacement shake. So they take it as their dinner. That's it. No other food.
Okay, thank you, Dr. Eliza. I hope it answers Dr. Nur's question. Maybe any other question from the floor? Yes. Your name and institution, please.
Good morning, Dr. Eliza. Thank you for your interesting presentation. My name is Salsa Bilarama. I'm a general practitioner. And I would like to ask, in Indonesia, currently there is a trend of public figure performing bariatric surgery procedures to reduce body weight rapidly, even though their BMI is not in the obesity category. So what is your view on this matter? Thank you.
Can I just clarify what's the BMI? Not obesity category, but 25?
Around overweight category.
So do you say Asia Pacific or WHO?
WHO.
So
WHO.
25
Yeah,
and
around
above.
25.
And your question is, what is my view on surgeons doing bariatric
Surgery.
on that low BMI?
Yeah.
Okay.
Okay.
So
thank
the
you.
indications for bariatric surgery really are a higher BMI, 40 and above, with no comorbidities, or 35 with comorbidities. That level has gone down to, in the Philippines, 30 with risk factors. So, of course, we cannot just do bariatric surgery left and right. We have to assess if the patient has already previous attempts on weight loss and failed. So there are patients who've already tried all the diets, all the pills, has already done exercise programs and still doesn't work. And if we see that there are risk factors, the patient is lower BMI but has at least one comorbidity or risk factor, then we can, I think it's an overkill if we do a sleeve, maybe a balloon first to prepare the patient for future interventions. Pharmacotherapy can be used in between. So to reduce your appetite, there are some tablets also to take out the early stat for the fat, and some injectables now. So I also have the same experiences. Sometimes the surgeons don't call us because they know we're going to say, no, do not do surgery yet. And then I just get the patient, surgery is already finished, but they're not that big. But there is a reduction in the risk factors. So these patients, after bariatric, their sugars or HbA1c improves. So they go off insulin or diabetic medications, and some of them no more hypertensive medications. So it's still helpful for them, even if we don't see that the weight really goes down. Not so much because their BMI is only 25. But we see that there is improvement after bariatric in those comorbidities. So as long as the bariatric surgeon doesn't call me before that, because I'm going to stop the surgery. I'm not going to give clearance, but when they come, it's okay. I just continue when I see them late. I'm not sure if insurance covers it. Back home, insurance doesn't cover bariatric, so they pay out of pocket. So that's why it's not as strict. If they want to do it, then we just let them do it if they're going to pay.
Of course. Okay, thank you, Dr. Eliza. Maybe there is only 1 minute left until 9:20. So do you want another question, or we should close this session? There's one question actually from the Zoom. So maybe you can open the slide for the last question, maybe. One brief question.
So right after this session, I will be running to another university because there are also a lot of obesity concerns there.
Okay, this is the last question. How to overcome obesity with mental health disorders such as depression?
Okay, so for these conditions, we call in the experts. So we have a psychiatrist in the team, and they work hand in hand with us. I'm not able to really manage the psychiatric or psychological aspect of the patient. So we get the expert to give them medications. A lot of these medications can cause more appetite and they get bigger. But there are newer antidepressants that have suppressant effect on the appetite. So we ask them to shift to that. And then we refer the patient to the psychiatrist alongside the program that we have, the diet and the exercise. So it's the same program with additional psychiatrists.
Okay, thank you, Dr. Eliza. I think this is it. Before closing this discussion session, I would like to give Dr. Eliza the opportunity to give her closing remark.
I'm trying to think of something witty. Well, obesity is a disease, and it's growing. It's now an epidemic. So hopefully the take-home message today with everyone here in the audience is, if you go back to your clinics and your families, to just bear in mind screening and assessment. Try to catch obesity early and help build the environment around it, not only the clinic, but your environment, encouraging more walking, encouraging less eating, and healthier foods. So with that, I think I'm just going to have gado-gado for lunch. Thank you, everyone.
Thank you. I would like to say thank you again to Dr. Eliza for the presentation and to all the participants for the active participation. Let's give another warm applause for Dr. Eliza. So now, all right, ladies and gentlemen, now we have come to the second session. For the second speaker, I would like to welcome Professor Gill to deliver his presentation on the topic vitamin-based interventions for the critically ill. Professor Gil Hardy, PhD, FRSC, FASPEN, is an emeritus professor at Clinical Nutrition in Auckland, New Zealand. He carried out research on glutamine and micronutrients in the Metabolic Research Laboratory of Nobel Prize winner Professor Sir Hans Krebs at the University of Oxford, UK, and also developed the first 3-liter parenteral nutrition bag for intestinal failure patients. He has over 250 publications from his nutrition and chyme reinfusion research, and his international awards include the Distinguished International Nutrition Support Specialist Award from ASPEN. He is a faculty member of ASPEN Board Director until 2022, founder and first chairman of the International Clinical Nutrition Section, and representative on the International Group on Human Rights for Clinical Nutrition. All right, Professor Gill, the floor is yours.
Thank you very much. Thank you very much. Salamat Gabi. Good morning. Thank you very much again for the invitation. It's a great pleasure to be here and to see you all. Can I first ask if any of you are already working in intensive care? How many are thinking that could be a good career to go work in intensive care? No, you all want to work with weight management. Oops. Can you go back? I want to acknowledge my friend and colleague, Dr. William Manzanares. I'm an academic researcher, but Dr. Manzanares runs the biggest intensive care unit in Montevideo in Uruguay. And over many years, we've collaborated in a lot of the studies and in reviewing the studies that I'll be talking about. So I'm sure most of you will have already learned and understood about all of the vitamins and the recommended daily amounts that we need in our diet for fitness and health. What I'm going to talk about is a few vitamins where we theoretically felt there could be a case for giving much higher doses and almost pharmacological properties. And what we wanted to try to do, first of all, I just go, oh, can I? Yes, these are my declarations. And then the next slide. So we want to concentrate on sepsis. I don't know the rate of sepsis in hospitals in Indonesia. I suspect it's quite similar to some of our other countries. It's over 500,000 patients in the United States and a similar number in Europe. half of those septic patients resulting from an infection will develop septic shock, and then around 50% of septic shock will die. So there's a very high mortality rate from sepsis. So the first takeaway message is don't go into hospital if you can avoid it. Next slide, please. My colleague, Dr. Manzanares, and I did a meta-analysis some years ago, 10 years ago now, and we looked at all of the studies that had investigate high-dose various micronutrients. And the next slide shows that there was indeed a lower mortality in those studies from the meta-analysis. So that was quite encouraging. Since then, there have been a few studies on specific micronutrients. And next slide. 2 large studies that looked at antioxidants, micronutrients in higher than normal doses, but they were quite complicated protocols that also involved investigations into glutamine dipeptide. The micronutrients administered enterally, parenterally, the indications and the types of patients were very mixed. So these were interesting studies. They got a lot of publicity, but many of criticisms have resulted since. So perhaps the second takeaway message is if you're planning to do research, try to keep the protocol as simple as possible. And it's very difficult within critically ill patients because it's quite a heterogeneous group. But the more complicated the indications and the patients, the less likelihood there is of getting quite definitive results. So in fact, the next slide shows that in the conclusions from these studies is that the high dose antioxidants were not indicated. Next. And perhaps one reason for this is this complicated series of pathways that I'm sure you all learned in your studies, but you can see many vitamins and trace elements such as iron and selenium involved in these delicate processes. So this eminent author suggested that this is such a delicate network that if we try to influence this with higher doses of any particular substrate, that could disrupt the balance and have some contribution to the variable results. Next slide, please. Starting with vitamin D then, that I'm sure you've already studied in your lectures. We all know how influential it is in bone metabolism. Perhaps less likely is the knowledge that it increases calcium absorption in the muscle and also in the gut, which is another particular interest of mine now. That so that's important for vitamin D. Of course, the best source of vitamin D is sunlight, but in many countries where the sun is too strong, and in New Zealand, from a very young age, we're taught to slop, to put on something and to slap on lots of sunscreen, and I suspect it's also true in your country. So there are deficiencies. In the next slide. And so this is another cartoon of the various pathways that vitamin D is involved in. So I shall be testing you on this at the end of the lecture. Next slide, please. So in summary, in the critically ill, some observational data is that the serum levels of the 25-OHD, that's the easiest marker to measure, if less than 20 nanogram per mil, it's found that about half of intensive care patients fall into that category. So deficiency of vitamin D is present prior to hospitalization and that we can do something about as it's a marker of sepsis. Excuse me. So if we can make sure that patients are not deficient in vitamin D before they end up in the intensive care, that's important. Low vitamin D blood plasma levels are associated with infection severity, so there's a correlation there. And lastly, the really low levels, less than 15 nanogram, have been associated with acute kidney failure. Next slide, please. And these are some studies that have then tried to address these problems, because billions of dollars have been spent trying to develop pharmaceutical answers to the sepsis without real success. This one looked at nearly 500 patients. They administered vitamin D supplement to those that were measured less than 20 nanograms, and they would, as their primary outcome, in measuring the hospital length of stay. So it was a placebo-controlled trial. Next slide, please. There were some positive results in that subgroup where they were really low levels of vitamin D, as shown on the left here. And both the hospital mortality, 28-day mortality, and even at 6-month mortality was reduced, as was the CRP levels, an indicator of inflammation. Unfortunately, there were no differences in the primary outcome of reduced hospital stay. Next slide, please. Another trial called the Violet trial investigated over 1,000 patients with some early screening. And again, less than 20 nanograms per mil were the indication. Their primary outcome was to look at the mortality, as shown here. And again, there was a smaller placebo group. Next slide, please. Again, disappointingly, there was no real difference between the study group and the placebo group, as you can see by these graphs. Next slide, please. The VIT-D-Eliza studies were also looking at 28-day mortality. Again, this time over around 2,400 patients, adults, and again with severe vitamin D deficiency, those less than 12 that we remember gave some positive results later on. This trial being carried out in Austria is still underway, and they are still recruiting some participants, so we don't know the results of that. That should be interesting. Next slide, please. So another meta-analysis that looked at the more recent studies, this was in 2018, and out of the 6 randomized controlled trials that they used, that they analyzed, they were unable to show any real improvements in mortality. Next slide. More recently, though, a systematic review with meta-analysis of around 2,500 patients in RCT, 16 RCTs, showed that there was a significantly reduced overall mortality with a P factor of 0.03. So that's encouraging. So there certainly seems to be some benefit in supplementing critically ill patients that are already deficient in vitamin D. Next slide, please. So to summarize then, the updated meta-analyses, there's a reduction in intensive care length of stay, there's a reduction in mechanical ventilation, and that the administration, either intravenously or intramuscularly, can have an effect on mortality. Next slide. there's still a lot we need to know and understand. So another take home for those of you interested in moving on into research, there's much research still to be done to investigate more fully the pharmacokinetics of vitamin D at high doses, which is the oral, enteral, parenteral or intramuscular are the best routes for most effective dosing. What is really the best dose to give, and that may vary for types of patients, and we need some better biomarkers to evaluate the pharmacotherapy. Next slide, please. And the FASPEN recommendations reflect these, so I won't dwell on that. Next slide, please. So again, just to repeat myself, in terms of future research, these are the factors that need more study, and that's an area where any of you interested in research could think about. Next slide, please. Moving on to vitamin B1 or thiamine. Again, thiamine deficiency has been observed in critically ill patients. It seems to work via the thiamine pyrophosphate, that's an essential cofactor and involved in carbohydrate metabolism and energy production. So there's certainly syndromes associated with thiamine deficiency, but they lack specificity and sensitivity. So on the right, I've listed those situations where low levels of thiamine might be suspected, and each of those will have some symptoms that simulate. Next slide, or next. The emphasis here is that we need multidisciplinary support, nutrition support teams to be aware that these risks may be present in those types of patients, so that early signs can be detected, or if not detected, at least treated. Next slide, please. Now, who can tell me what the Krebs cycle is? Anyone want to volunteer? No, I can never remember it, and I work with the man. This is the original Krebs cycle on the left that Professor Krebs himself, when he was just Dr. Krebs, wrote. And on the right, that you probably can't read, but it's the rejection letter in 1937 from Nature, one of the most prestigious medical journals, rejecting this concept of a cycle for the tricarboxylic acid that later went on and was responsible for him receiving the Nobel Prize. So again, a moral there is if at first you don't succeed, try and try again. Don't give up, be persistent in your research. Next slide. This is an old lab shot where I had the pleasure of working with the great man, and this is his other Krebs cycle as shown in that photograph that he allowed me to take. Next slide, please. So here it is. Here's the Krebs cycle, and if we press again the slide. Next, please. So it's essential for any metabolism, I'm sure you know, but you see where the TPP is a key factor in several points around the cycle. Next slide, please. An early investigation into different types of critically ill. This is cardiac surgery. So after coronary artery bypassing, you can see on the right of the graph there that post-operatively the thiamine levels drop quite substantially. Next slide, please. But intervention by giving around 200 milligrams of thiamine didn't appear to improve the situation. This shows lactate levels in septic patients, septic shock, deteriorating over the course of days. Next slide. So here's one of the first monotherapy investigations, 200 milligrams intravenously compared to placebo, and that certainly improved survival in those critically ill patients that were deficient in in thiamine. Next slide. This, another one, this is from 2018, where they looked at lactate levels and 28-day mortality. And again, next, you can see the slide, next slide, please. You can see the lactate clearance was improved with thiamine. Next. And the 28-day mortality was also improved. We mentioned earlier, it's important in kidney disease, and you can see comparing the blue, which is thiamine, those levels are consistently much lower than placebo. So this was quite conclusive that parenteral thiamine decreases the creatinine levels, and it may reduce the progression of those with kidney disease to hemodialysis. Next slide, please. Moving on to vitamin C, I'm sure you all know about vitamin C being the most important antioxidant. So I'll move on from that to the next slide. And the next. Yes, next slide. It's involved in the immune system, neurological and gastrointestinal and many other systems. Next slide, please. I want to get on to the clinical studies. So pharmacokinetics are very important to understand. We don't know enough about them. Next slide, please. So here's a Lovett study looking at giving enhanced amounts of vitamin C to intensive care patients every 6 hours for up to 4 days. Next slide. And these were septic patients. And you can see that actually the conclusions were disappointing again, that there was no real benefit from giving the high doses of vitamin C. Next slide. An updated meta-analysis of the various vitamin C studies and mortality shows that it may be beneficial, but there's still much more work that needs to be done. Next slide. And the next. Still more evidence required. These are interesting. This is an intensive care doctor in the United States who developed this HAT cocktail. This consists of hydrocortisone, vitamin C, and ascorbic acid and thiamine. And in his initial studies, just looking at mortality, giving this cocktail at the dose is shown, clearly there was a reduction in mortality and in the norepinephrine levels on the right-hand side. Next slide, please. And the next. This is called the vitamins randomized trial that was done in 2020. 200 patients, again, this enhanced levels, 1.5 grams of vitamin C, and I think it was 200 milligrams of thiamine. Primary outcome, looking at duration of the vasopressor levels. No differences between the groups. And the next slide. This is the ACTS trial, again, using the HAT cocktail, slightly less thiamine, only 100 milligrams here. And again, no difference in the supplemented group from the placebo group in the SOFA score, which is an indication of inflammation. Next slide. And the VICTUS trial, similarly, no real improvement in ventilator-associated ammonia and vasopressor usage in these patients. So rather disappointing, lots of criticisms one can make with hindsight to the protocols, but nevertheless, next slide, please. We've summarized, if you're interested in reading more, we summarized all of these data in our review earlier this year. And so please, if you can't access it directly, I'm sure you can, but if not, I'd be happy to send you a PDF of the paper. Next slide. So to summarize then, we still need more data, more research, and more knowledge about the use of these high-dose vitamins in septic shock. Many of us believe that if we get the dosage and the other factors better understood and using better protocols, better studies are carried out, we can certainly start to demonstrate more benefit. The only one there is really a strong recommendation now is shown with acute kidney injury, where 100 milligrams of thiamine are recommended. Next slide, please. Coming to the end. So the take-home messages then, excuse me, there's an intensive care critically ill patients do exhibit low micronutrient blood levels, and these are closely associated with poor outcomes. The recent randomized controlled trials that test high-dose micronutrients, such as thiamine, vitamin C, and D, have some benefits, but they failed really to demonstrate major clinical significance. The very high single pharmaconutrition with vitamins cannot be advocated at the moment. And so we're back to the drawing board almost to look at future trials that understand more the pharmacokinetics, develop better biomarkers to identify and monitor the intervention. So much research for anyone who's interested to follow that path. And the next slide is, I think, the last. Thank you.
Thank you very much, Professor Gill, for addressing this interesting topic. So we will now move along to the third speaker. I would like to welcome Professor Hamid to deliver his presentation on the topic, the role of dietary vitamin K in cardiovascular disease and bone health. Professor Dr. Hamid Jan bin Jan Muhamed, FNSM, is a professor at the Department of Nutrition, School of Health Sciences, University Sains Malaysia since year 2007. He initiated the first birth cohort in Malaysia named the USM Pregnancy Cohort Study, which started in the year 2009. His research interests are maternal and child nutrition, obesity, nutrigenomics, clinical nutrition. Currently, Professor Hamid is working on several intervention projects related to prevention of stunting in children. He also works closely with the Ministry of Health Malaysia by being committee member of the Technical Working Group for Nutrition Guidelines and other consultative activities. He serves as the chairman of the Technical Working Group for Nutrition Research for the Ministry of Health Malaysia. For the Ministry of Health Malaysia. He is also the scientific committee member of the International Life Sciences Institute, Southeast Asia, and committee member of the Developmental Origin of Health and Disease or DOHAD Society. All right, Professor Hamid, the floor is yours.
Thank you very much. Assalamualaikum and very good morning, everyone. How are you? Apa kabar? Okay, so I have 30 minutes to cover this topic, and the topic that I suggested is to look at the role of vitamin K in cardiovascular disease and bone health. Bone health, okay, I would start my lecture by talking a bit on bone health, and then I will go into vitamin K, and also going through how vitamin K is interrelated to cardiovascular disease. So as we all know, the risk of osteoporosis is very much related to bone health, and elderly, they experience fall and fractures due to the lack of strength in their bone. Next. And next one. So this is a figure of how in 200 days our bone goes through a process of mineralization, and then the resorption, reversal, bone formation, and etc. So it's a dynamic process between calcium and other nutrients inside our body that strengthens our bone. Next, please. And we have all seen this probably before, the importance of bone density reaching peak at the age of 30 years of age. And you can see from this, at the age of 30, the peak bone mass in the man, okay, will be arriving and then followed by the female. However, you can see after that, women lose bone mass more rapidly than men. So I like to use this picture to educate the public on the importance of having adequate amount of bone nutrients early stage. Okay. Sometimes, people start to be cautious, they start to take multivitamins, multiminerals, milk, etc. when they are old, because they thought, oh, I am old now, I should drink milk. The benefit will not be as good as when you studied at young age, because you need to have a positive deposit of bone nutrients when the bone are reaching the peak bone mass level. So this is very important slide for educating the public on having good nutrients at early age. Next. Again, a repetition of the previous one, but this is to highlight the estrogen deficiency accelerates bone loss in postmenopausal women. Excuse me. Postmenopausal women, because of lack of estrogen, they will further go through a process of bone loss. Next, please. And bone is a very important organ. It builds our structure. So optimal bone health is not only calcium and vitamin D. So we can see all the other minerals are also involved in the formation of the strong bone, meaning that we should not be focusing on one single nutrient and hoping that that single nutrient will do its job in ensuring us to have a strong bone. On top of these minerals, we are going to discuss another two, which is vitamin D and vitamin K, so that we complete the puzzle and complete the picture on the important nutrients on bone. Next, please. So I would like to share this study on a patient pool analysis, about 68,000 patients, several major vitamin D fracture trials in the US and Europe. Next, please. So in this trial, they have successfully shown the importance of co-supplementation, meaning that if you do not give anything, this is calcium, this is only the vitamin D trial, looking at the fracture per 1,000 people and hip fracture per 1,000 people. By only giving a single nutrient, which is vitamin D, the risk of fracture is still quite high. But however, the red dotted line showing you calcium together with vitamin D will give a better benefit in prevention of bone fracture and hip fracture. And normally the pharma industry will hop on this first, because if you remember, previously on the shelf in the pharmacy, there are only calcium supplements, right? Now we can see calcium plus vitamin D supplements. And lately we are seeing calcium plus vitamin D plus vitamin K supplements. These are the evolution of supplements. As how science develops, the evidence comes in, the pharma industry will use this evidence to produce solutions for them from their perspective to the community and public by innovating the supplement tablets. God knows after this what will be there, but I think at the moment vitamin K is getting a lot of attention, and that's why I suggested that would like to share a bit of my knowledge on vitamin K with you all. Next, please. So going back to vitamin D, back in year, I think 2014, I published this paper on the vitamin D level in the breast milk of Malaysian mothers. This is an accidental research, basically. Initially, I had this USM pregnancy cohort. I have all the bio data, biobank, and I've been storing the woman's breast milk, serum, and etc. in the freezer. So one day, one milk company came to me and suggesting to use my samples to evaluate vitamin D analysis. So we sent the sample to New Zealand. It's from Fonterra Research Institute, and they are the one who analyzed the vitamin D level in the Malaysian mother's breast milk. And I would like to say humbly that this is the first evidence that we have to share that we are able to measure and publish and evaluate the vitamin D level in the mother's breast milk. Next, please. So before that, we would like to share the vitamin D status of the pregnant mothers. You can see how in the second and third trimester, mostly of them have either severe, mild deficiency in the second trimester, and then in third trimester, they have more insufficiency. So sufficiency is only 5.9% in the second trimester, and it increased to 22.5% in the third trimester. But again, because it is still very low, to be honest, for Malaysian. Although we have sun all the day, every day we have sun outside, but we do not go under the sun. Look at us today. We are here, the sun is outside. This light is not giving you any vitamin D activation. And even if you go outside, you will be either under the shade, you will be under the umbrella, or you will have SPF 5 million or 1,000 covering. So scared of being dark, and then so scared of the sunlight. So all these barriers did not give us any advantage, even we have the sunlight free of charge. So like it or not, and another one on top of that, our diet is not the same as the European diet, where they have more milk consumption, more cold water fish consumption, not like here. Probably what fish do you normally eat here? Okay. Lele. Ikan lele have no catfish. Ikan lele is catfish. No, there's not enough vitamin D there. Okay. So next, please. So moving on to the study, that we noticed that mothers who are taking multivitamin supplement has a better vitamin D serum level in the second trimester and in the third trimester. So this analysis is showing that when a mother takes multivitamin, when she is pregnant, the level of vitamin D in the blood and in the breast milk will be higher compared to mother who do not take multivitamin supplement, which includes vitamin D. Okay, so the problem in Malaysian mothers, I'm not sure in Indonesian mothers, is they will stop taking supplement after delivery because they thought the job is done. The baby is out. I'm no longer connected with the baby through the placenta, so I do not need to take supplement. That is one of the biggest mistakes that Asian mothers are doing. Because why? Through breast milk, you are still connected to the baby. So the breast milk is very important. So the mother should be well nourished so that she can give maximum or optimum benefit from the breast milk to the baby through the breastfeeding process. Next, please. Yeah, again, we showed a correlation between maternal serum and maternal breast milk, but the association was not very strong because we did not have big sample size probably. Next, please. And this is a review of vitamin D in research level in Malaysia. So I'm sharing some papers back from 2004 until the one that I did publish last year with my PhD student. We can see the 25 hydrogen vitamin D at the level of sufficient is 26.7, 27, 33, or around 20% of Malaysian mothers, not mothers, the population have a vitamin D level in their blood. So it's not very good. So you can imagine how is it going to impact their bone health. If they do not have enough vitamin D, it may affect the bone strength of them, especially when they are old. Next, please. Okay, next one. Okay. In my study, we tried to do an analysis. So effect of occupational sunlight exposure. This is the paper published in MJN, Malaysian Journal of Nutrition. Very simple study. I have two groups of sample. The first group are office workers like you and me who sit inside building throughout the day. Okay, that is group number one. The second group is people who work outside under the sun directly. Can you guess who are they? Yeah? Huh? Labor workers, they still work under the shade. These are people who sit betul-betul bawah matahari. Huh? Farmers, fishermen. Farmers can still have a tree, you know, so they can hide under the tree. So we found fishermen as the perfect model of people who work under the shade. And to be honest with you, when I talk to them, and we do like have one questionnaire on the clothing, you know, clothing index, how much they wear during their work. So the office workers will have high score. Basically, they wear tie or long sleeve and etc. And the fishermen, they say, we just wear underwear. I was like, I don't believe him. Are you sure? He said, yeah, we go in the sea. Nobody see us. And it's so hot. And either they wear short or anything, they just remove their shirt. And that's why they are all dark. The whole body, if you see them, they are sunburned everywhere. So I say, it's okay. It's good for my research anyway. So, so we did a comparison of their blood serum level of vitamin D. And can you guess the result? Any wild guess who has the highest vitamin D? Fishermen. None of them has insufficiency or deficiency. Perfect model for vitamin D. Okay, so this is the result. We can see. I did this study in monsoon and non-monsoon season. You know monsoon season? You have monsoon season where there is a lot of rain, musim hujan. We call it monsoon rain. In Kelantan, where I live, we have monsoon season from September until January, February. So the sea will be very rough. Fishermen doesn't go to the sea. So we can show here, this is the outdoor and indoor workplace. These are the fishermen. These are the office worker. You can see their mean vitamin D is 126. And it drops a bit during the monsoon season. But still, they have more than 100 nanomole per liter, although they don't go to the sea. Why? Because the fat-soluble vitamin, it is stored inside their body for reserve. And this is the mean value of the office worker. Whether it rain or doesn't rain, they are not affected. They still remain the same. Okay? So this is the first finding of the reason why we have low vitamin D, probably diet, and second is the occupation that is causing that. Next, please. Yeah, this is the board. Okay, next one. Okay. Child stunting is on amino acid. Now I want to move on. So before I move on to this, I shared this data to the office workers. I say, hello, you are all deficient, and you lost to the fishermen. And they were very upset. Okay. So they say, Doc, you can't expect all of us to become fishermen. No one will process the documents, So they asked me a solution. If I, as an office worker, want to get adequate amount of vitamin D from the sunlight, what is your prescription? So I cannot answer that question because I do not know how long you should sit under the sun as an office worker. So I designed a randomized control trial. I have a placebo group. All are vitamin D deficient. Placebo group, vitamin D supplement. We gave 50,000 IU per week orally. So they take the supplement in front of the researcher. And the third group is the poor group, is the sunbathing group. So the sunbathing group have to go under the sun and they have to lie down at the padang, at the field for 20 minutes, 2 times per week at 11 a.m. Because the ethic committee not allowing me to grill them at 1 p.m. 1 p.m. is the best time to get vitamin D activation. Do you know that? Who say true? 1 p.m. is the best time for vitamin D activation. No. Who say 8 a.m. is the best time for vitamin D activation? So, what is the best time? 8 p.m.? One, who say 1? Angkat tangan. Who say 8? Okay, I'll move on. No response. Okay. Some people thought 8 o'clock in the morning. Why? Because the mother told them, go out early morning, the sun is good for your health. It's all bluff. Okay. They just want you to get up from the bed early morning. It's not 8 a.m. It is 1 p.m. during Zohor to be easiest time. When the sun is exactly on top of your head, that is the best time because the UVB is the highest. But we cannot tolerate the heat. So the ethic committee say you better grill them slightly earlier. So I grill them at 11 a.m. So the sun is not very hot. So I have 3 groups, 3 different methods. So I want to ask you, between these 3 groups, who had the highest increase in vitamin D after 3 months of intervention? Supplement, placebo, sunlight. Sunlight. They have the same effect. The increase, same, very high. All from becoming deficient to becoming almost normal. And the sunlight group is free of charge. The supplement group you have to pay. So now you decide, okay? But it is not really pleasant. I have one participant lost her boyfriend from the intervention. Because he prefer white skin, so they say, no, I cannot. You will become a bit tan. Gelap sedikit. You will become a bit tan because of the sunlight. So I'm surprised the ethic committee allowed me to do that. But anyway, we are going to publish that paper very soon. All right, let's move on from vitamin D to amino acid. So this is a paper highlighting the importance of amino acid for stunting prevention. So next, please. So it is highlighting the importance of arginine, where it has shown that arginine increased width of growth plate in the rat. So they did this experiment in the rat and they compared control and intervention. So the intervention received 0.045 arginine was mixed with 1 ml of water for 28 days. And they showed that there is an increase in the width of growth plate in the rat. So it can be replicated. If a child is not getting all the adequate essential amino acid, it may cause stunting. So you can reflect this because studies have shown that children who consume milk, which has all the essential amino acid, has a better height compared to children who do not consume milk. So that is one way of relating this arginine and amino acid with stunting. Next, please. So arginine promotes growth in children. Okay, so you can see children with an arginine intake between 2.8 to 3.2 gram per day grew 0.3 centimeter faster compared with those who intake arginine was less than 2. So this is the low arginine intake. So this is the higher arginine intake. You can see that their height velocity is growth velocity is higher compared to that. And also if you compare serum arginine level in stunted children was are lower in the stunted children compared to the non-stunted children. So you can see how not only mineral, not only vitamin, amino acid also plays some role in preventing or in having a good bone growth and growth velocity. Next, please. So again, this is the repetition of the previous slide that I've shown. Next, please. Now we go to the vitamin K. Just now was just mukadimah, just an introduction. So now we go to vitamin K. How many minutes I have? 8 minutes. Okay, we'll try to finish. So I think I will not explain in detail. I think you are all experts in this area. So vitamin K in general, you can have phenolquinone or menaquinone. Phenolquinone is found in green leafy vegetables, and then menaquinone is in animal food, and also it is produced by bacteria in our body. Next, please. And traditionally, vitamin K is known as a blood clotting vitamin. The K comes from the Danish word coagulation. That's how the history was. And now science have shown that it is also important in bone health and heart health. So in today's lecture, I will elaborate more on this. Next, please. Yeah, I want to refer this Malaysian RNI, recommended nutrient intake, to show the intake recommendation for vitamin K. Next, please. And foods, this is the content of food. I'm using this because I think Indonesian and Malaysian has similarities. So you can relate some of the food here with your food. So phenolquinone in plant food is tightly bound to chloroplast, so it is less bioavailable than that from oil or dietary supplement. For example, the body absorbs only 4 to 17% as much phenolquinone from spinach as from a tablet or from supplement. So you can see the high level is in mustard leaf, in spinach, but then the bioavailability is not very high, okay? And these are all the other green leafy vegetables that you can get your vitamin D from. Vitamin K from. Some oil, cooking oil like soybean oil, canola oil, they do also have vitamin K. So next, please. That is K1. Now we go to K2. Natto is a very popular food in relation to vitamin K. Anybody have tasted natto before? Not lato, but natto. Natto is a Japanese fermented. I have not eaten that, honestly. But someone told me the smell is really unacceptable. Is it correct? I don't know. Baunya pelik kata. So, but then it has one of the highest level of vitamin K2. Jill, have you tried natto before? Oh, yeah, it's in Japan, it's very popular. It's fermented. This is how it looks like, with some sticky, gluey things. You know, if you can tolerate, you can't tolerate. It's very, you will have very acquired taste for that. Okay, so natto is a standard English language use. It's a traditional Japanese food made from whole soybean that has been fermented with bacillus. So it's with a bacteria. So I think if you do this, tempeh would be the closest. You ferment soy, but with fungi. Is it? Right? Kulat. Tempeh. Have you tried tempeh? Yeah. So tempeh is something, but it's not really like natto. Natto is the bacteria, is the one that increasing the vitamin K level. So we have very high level in natto, but no one eats that. Okay, some in beef, chicken, animal source like cheese and etc. Okay, so this is where you get the K2 from. Next, please. But the sad news is in Malaysia, 90% of Malaysian adults do not eat the recommended daily amount of both fruit and vegetables. We have shown to you that K1 is high in fruit and vegetables. But if you do not eat fruit and vegetables, then the risk of not getting it from the fruit and vegetables is high. So only 5% are achieving the recommendation. And I believe this 5% probably the vegetarians in Malaysia, because they are able to achieve because they eat more than the non-vegetarians. Next, please. I'll skip this, next one. And I was trying to find papers, publication on the prevalence is not many out there. Not many papers have published vitamin K prevalence. I tried to find in Indonesia. Yesterday, I was trying to go through the Google Scholar. I couldn't find any. I don't know. But this is one of the paper based in Malaysian population. In patients, they use this PIVKA method. It's quite indirect. It's not a direct method to measure vitamin K. It's difficult to measure vitamin K directly. So you use indirect method and then you relate with vitamin K. But they say that the prevalence was quite high, about 28.9% insufficient through this indirect method. Next, please. So who are at risk of vitamin K inadequacy? May be newborn who are not treated with vitamin K, people with malabsorption disorder, long-term antibiotic usage because it kills off the gut bacteria, and then warfarin, bile acid concerns, or Listat. So these are some drugs that may affect the level of vitamin D in the patients. Next, please. So the way that vitamin K strengthens our bone is through the formation of, through the activation of osteocalcin, which is important for bone strength. Next one. And nutrients that contribute to growth promotion. So you have vitamin K. Okay, vitamin K will, for example, supports bone formation and suppresses bone resorption. So this is through the osteoprotegerin stimulation. There is a mechanism involved how the bone formation is increased by vitamin K. Next, please. Again, osteocalcin activation plays a key role through this process. Next, please. Yeah, this is an intervention data showing you in adult vitamin K induced osteocalcin carboxylation within the first 3 days, and this effect continue in an upward trend until the end of the study period. This is a randomized trial showing you the difference with no supplementation, K1 supplementation, and K2 supplementation. So the K2 is the one that has a stronger contribution towards the formation of healthy bone. Next, please. Okay, next one. I'll skip this one because of time, okay? Next, please. Now I want to focus on the cardiovascular system. Lately, there are a lot of papers suggesting the role of vitamin K in prevention of cardiac diseases. So vitamin K activates matrix GLA protein to inhibit calcification of the arteries. So you can see sufficient vitamin K, no calcium deposition arteries are more elastic and soft, while the one with lack of vitamin K has more calcium deposition. So there is a CMGP activation process involved which takes away calcium from the internal part of the blood vessels, clearing the blood vessels from the risk of atherosclerosis and also stiffness of the arteries. Next, please. So there is a study shown on the menaquinone 7, which is the vitamin K2 supplementation, improves arterial stiffness in healthy postmenopausal women. It's a double-blind, randomized clinical trial. Next, please. And you can see the stiffness index, yeah, on the treatment period, and also the CPWV. This is the also stiffness index, I guess. You can see in the treatment group, or in the vitamin K supplement group, which is the open symbol, it is reduced. It is less stiff in the supplemented group compared to the control group. Next, please. So the summary of this lecture, I think novel function of vitamin K in community and clinical settings warrants further investigation, particularly in Asian communities or population. I think we need to do a lot of work. There's a lot of research opportunity in vitamin K research. It's good idea people start to venture into this and try to see if we could find some interesting findings from the study. There is lack of data. As I said, when I've been doing research, there are a lot of data outside there, but not in this country and in Malaysia that we could leverage on. And we could do more research in this area. At least if you cannot measure the vitamin D level, vitamin K level, we can do some work on measuring the intake level. And from there, we can try to postulate whether the intake is sufficient or the intake is not sufficient. I think with that, next one is the thank you. Terima kasih banyak-banyak. Assalamualaikum.
Thank you very much, Professor Hamid, for giving us such an interesting presentation. So now I invite Professor Gil and Professor Hamid to sit up front so we can start the question and answer session. For the online participant, both Zoom and YouTube, you can post your question in the chat box. For the offline participant, you can raise your hand and deliver your question by mentioning your name and institution. Okay. Thank you. First, for Professor Gil, there's already a question in the Zoom. So I will read the question. This is from Laurencia Ardi, our clinical nutrition resident. So she asked whether thiamine supplementation in the critically ill, do we need to check the thiamine level first in the patient before we give the supplementation, or we just supplement the patient not checking the level first?
That's a challenging question. Thank you. Oh, it's online. Yes. In principle, we should check as soon as the patient arrives in the intensive care unit. In practice, that's often very difficult. The problem, many hospital labs don't routinely have the test available. And so that's life, I suppose. Life is never perfect. But if we have the facilities, then it should be checked early on with those that are deficient. And so if you've got the facilities, then by all means test. I think that's true of all micronutrients, actually, but most labs are still not sufficiently set up to do that. So that's something we have to continue to lobby for and encourage. I think that's probably true of vitamin C and D as well. And yeah. Yes, either not available or very expensive tests. So
maybe if we have the facility, we should check first, but if not, then we just supplement.
yes, well, if in doubt, especially in intensive care, I would supplement. It's not a particularly expensive micronutrient, and so I think it's not it's not particularly toxic, it's quite safe. So the recommendation is probably to assume your patients are going to be deficient either when they arrive or soon after if they've had a major incident. Otherwise, they wouldn't be in intensive care if they hadn't had a serious event. So they're more than likely to be thiamine deficient. So best to supplement and then monitor later if you can.
Okay. Continuing to the question, Professor Gill. Do you recommend to give thiamine monotherapy supplementation or with in conjunction or in combination with the parenteral nutrition?
Yes, well, it should be incorporated in all parenteral nutrition at the recommended daily amount and up to 200 milligrams. And apart from being important in the critically ill, it's also very important against refeeding syndrome. If you're starting parenteral nutrition and the patient for various reasons hasn't been eating or feeding properly prior to parenteral nutrition, as many of you will know, if you immediately start, and this was found after the wars, for example, when all these malnourished people, soldiers were found, they immediately fed them lots and lots of food, and many of them then deteriorated because of this refeeding syndrome that affects the brain and lethargy and confusion and so forth. So there's good reasons to, well, first, it's essential to supplement all micronutrients when you start parenteral nutrition. And secondly, to avoid refeeding syndrome, thiamine and phosphate. And that's also a remedy if you haven't seen it and refeeding syndrome has started, then the therapy against that involves thiamine. And then if they're critically in the intensive care unit, then consider the higher dose.
Okay, thank you, Professor. I think the answer is quite clear. So maybe another question from the floor. Is there any question? Yes.
Good morning, Prof. Gill and also Professor Hamid. Thank you so much for the interesting lectures. I'm Nadira from Clinical Nutrition Resident. So I would like to ask to Prof. Hamid about the vitamin D actually. So is it necessary for us to check for the UV index first before deciding which time is the best to sunbathe? Because you said it's 1 p.m., but generally in Indonesia, we have like different areas when the sun exposure is also different. Or you think 1 p.m. is actually generally the best time for us? Thank you.
So the question is about sunbathing time. I think for the Muslim woman, it's very challenging because we don't sunbathe like the Australian or the British. The study that I did was very tightly controlled. They have to go to the field where no one is there. I cannot be there because I'm a male. So my PhD student is a female. She's the one who's been managing that. So they lie down with sunglasses because it is too bright. They expose their face, arm until here, and then ankle area. Very minimum. No need to wear bikini. Okay, so just wear a very expose a very minimum to that level. So they have some challenges in terms of tolerating with the heat. As I said, we didn't do it in the peak time. It was around 11, but probably here is 10, I think. 10 a.m. in Indonesia would be okay. I'm not saying that if you do it in the morning, you will not get the benefit. The intensity that you will get will be lesser compared to when you do it at the noon. So you will still get the benefit, but not as much as compared to the noon. So in that case, I think 10 a.m. is still okay, but then you have to be consistent. Right? In that study, we did it only for 2 times per week. It's not every day that you have to do that. And I think it is a nice way of trying to get some activation of vitamin D through the sunlight. And I think in this region, there is no big issue on skin cancer related to the sunlight. I did have a friend in Malaysia, it's a skin specialist, and he didn't say that it's going really to cause skin cancer unless if you are sensitive to the heat. So I have one girl who in 5 minutes, she turned from white to red. Totally red because of the heat. So we have to exclude her from the study because she cannot take in the sun heat. So I think in a short message, I think the message is not that we should have like a jadwal, you know, I must go at this time and this. I think we should have the habit of at least getting from the sunlight. When we are walking from here to the car park, try to avoid the shade, try to avoid, you know, you won't die, you know, no one has ever died from, you know, the heat unless it hits shock or hits stroke. But the message was to have that kind of practice. In one day, you know, one or another day, go a bit under the sun. That's all. Thank you.
Okay, thank you, Professor Hamid. There is another question for Professor Hamid from the Zoom. This is from Ananda Putri Tarigan. She didn't mention the affiliation. So this is the question. Do you think that the use of high protein local foods can be recommended in supplementing for children with stunting? Will it promote growth in those children? Thank you.
I think protein is an important component for growth in children. But I would not say go for high protein. I just go for adequate amount of protein. Go for high protein, you may risk the kidney. You may burden the kidney of the child. I don't want like parents to start to do like Herbalife shake and give to their children and thought that this high protein shake can grow them because it is high protein. That is for different purpose. But my advice is not high protein, but adequate amount of protein which has all the amino acids component so that the child will get adequate amount of amino acid so that the growth can be promoted. I think the challenge and the issue in Malaysia and probably Indonesia is that children are eating protein, but probably it's mostly plant protein. So when you take plant protein, it does not have all the amino acid, then it may have some effect. And also milk consumption, as I said earlier, is one of the important component of food groups that may promote growth. It's like liquid, easily consumed, and should be promoted, especially in children. Thank you.
Okay, thank you, Professor Hamid. So we need the balance of animal protein and protein from plants to gain adequate amount of protein for the children with stunting. Okay, thank you. So there is one question from Professor Gil to Professor Hamid.
More than one, probably. Yes, I believe the watermelon is very high in arginine, and I see that everyone here in Indonesia, certainly in the hotel where I've been, there's lots of watermelon, so that should be quite good. I'm particularly interested in glutamine that I know you mentioned in the first slide, but there wasn't any data, or is there any data on perhaps supplementing with glutamine? Because that could be a bit more beneficial as well, and it's actually protective of the kidneys, so you might be able to supplement with glutamine, which is essentially helping with the protein. Yeah. Are you aware of any data? No. Okay.
Okay. For the next question, maybe from the floor. Is there any question? Yes.
Good morning, Professor Gil, Professor Hamid, and Dr. Safi. My name is Jocelyn, and I would like to have question for Professor Hamid. The first question was, there is the risk factor for patients who have malabsorption of vitamin K, and what is your suggestion for those people to increase their vitamin K? And the second one is still the problem with sunbathing. You said the morning and the noon has different intensity. Will the morning, if you're sunbathing in the morning, is the duration will matters differently with the noon sunbathing? Thank you.
I think I'll answer the second one first. I think it's dose dependent. You basically, when you go under the sun, you get the UVB radiation, and the response by your body is dose dependent. I've seen some study comparing duration and time as well. So they concluded that it depends on the dose as well, how much dose of radiation that you are getting. So yes, if you think that if you can tolerate the morning sunlight and you can lie down a bit longer, then it will benefit you in another way. And if you go for the noon, you just have like espresso, very short, one shot, but it takes some time as well to have this effect. Okay. The first question was about supplementation. Well, I don't deal with gastro patients. I'm not sure, Gil, you deal with gastro-related patients?
Not directly anymore.
Okay. Maybe Gil can add more onto the comment. But I think in general, if we see someone have like inflammatory bowel disease or things like that, we are well aware the absorption of nutrients will be affected. I think a low dose or moderate dose of multivitamin may help to improve their mineral or vitamin absorption. That's my short answer for that. Maybe Gil can add more as a clinician perspective.
Yes, I think that's very true. And I noticed on your slide that you indicated that bile was quite low in vitamin K. And I was wondering, is that just related to the diet or the environmental factors, or related to some sort of the actual disease or any surgery that's
bile binds to the vitamin K and then it prevents absorption. So when you have this bile level is very high, then it prevents the absorption of vitamin K, and that's how it becomes low. Yeah.
So colorectal patients probably would have low vitamin K levels, yes, and that would apply to the chyme that, in addition to bile, I suppose. Yeah, that's another interesting area of research then.
Okay, thank you, Professor Hamid. Maybe for the next question from the floor.
Good morning. Thank you so much for your presentation. I would like to ask a first question for Prof. Gil. During your presentation, vitamin B1 or thiamine is used as therapy in critically ill patients. I've read that heart failure patients are given high doses up to 300 milligram. Actually, why we need to give such a high doses very far from the recommended doses for that patient? Thank you. And for Prof. Hamid, I would like to ask about a topical sunscreen, because is it really that topical sunscreen inhibit vitamin D synthesis from skin? Because some study give conflicting results, and then there is literature that said vitamin D deficiency is pandemic in the world, and is it polymorphism of vitamin D receptor have role in it, or only the sun exposure is the that responsible for the deficiency? Thank you.
Maybe Professor Gil first. So the question is, why do we need to give a high dose of supplementation of thiamine? Because in the slides you say that you need to give 200 milligrams, which is above the recommended amount of daily allowance. So why the need for a high dose for the critically ill patients?
Yes, that's a good question. It's really because we at least half and probably 3/4 of the intensive care patients are deficient, and even if we can't measure it as we were discussing earlier, they're most likely deficient, and so in that case, there's a good argument for giving more than the recommended daily amount that you would to your in the community or even to your regular post-operative patients. So in the lower amount, as you're suggesting, would be appropriate in routine parenteral nutrition, for example, or enteral nutrition. But the higher doses, even though the data for the really high doses of the study, some of the studies were looking at 400 milligrams, didn't have that pharmacological effect that some people were hoping for. But I think the 200 milligrams, is going to protect against refeeding syndrome if you're increasing your parenteral or enteral feed. And secondly, assuming that most, if not all of the intensive care patients are going to be low in thiamine, then there's a reason, an argument for giving that dose.
Okay, thank you. So maybe because why we give a high dose, because in the critically ill, it's not the normal patients. There's very sick patients with probably very low level of thiamine. So we need to give them more than the recommended daily allowance dose. Okay, next, maybe Professor Hamid. Yeah, I think so. The topical sunscreen, so is it inhibiting the vitamin D receptor?
All right, excellent question. The mechanism how we do not get vitamin D from the sunlight has a lot of barriers. If you drive a car with a tinted window, that will prevent ultraviolet B radiation from entering your car. You will not get the activation because of the black dark screen. If you live in a house and your house is tinted with black dark window, same thing. But on the body, normally the manufacturer of sunscreen, they have UVB protector. They have some index, ultraviolet radiation protection index. And this index, the higher the index, the lesser vitamin D activation will happen on your skin. And to make things worse, even if you have sweat on your skin, it will still become a barrier. So there are so much barriers that you have to make sure your skin is dry and you get direct exposure to get the direct benefit. So to answer that question, yes, although she said there is a conflicting result, I'm not sure. Probably if you are using a sunscreen without UVB protector, then that is a good one. But the one with UVB protection will definitely become a barrier. And she also asked about a question about genetic. There are some studies, on nutrigenomics. My students did also one study in Emirates on polymorphisms of vitamin D genes, but we do not see any good association. So basically, the short answer is you cannot blame your gene for having low vitamin D. That is the current understanding. Thank you.
Okay, thank you,
so
Professor
much,
Hamid.
Prof.
There are 2 more questions from online questions. Maybe please share the slide. Okay, from Sistia, from Faculty of Medicine, if our bone mineral density has decreased and we have risk to get osteopenia in the late 20s, whether this condition can be improved or can be managed, and what's the tips? Maybe for Professor Hamid.
Okay. Yes, as I said, if you look at the graph just now, it's showing you like increase and slowly decrease. It doesn't go straight down. You know, it's a process. It's a process. And there are some studies that have shown that even at older age, if you take adequate amount of bone mineral and do some physical activity, because physical activity will synergistically help you to improve your bone, not just taking supplement. So you have to also make the bone work with some kind of activities. Then it will still give some contribution. The only difference is the benefit is more superior if you do it at early, during adolescence, during early adulthood, the benefit will be more superior, but it's not the end of the day. It means even if you are at this age, at late age, you can still have a strong bone, but you have to be vigilant on the nutrients that you take and the physical activity that you take.
Okay, Professor Hamid, maybe I want to add another question. So if we get plenty of exercise and we eat good amount of minerals and vitamin K and vitamin D, can we get the chart to go up, like we get to gain the bone mass, or we just prevent the reduction of bone mass?
I think you can just prevent the severity. I think to reverse it, I am not sure of any study that have shown that you can reverse the process, meaning that you go back when you are 30 years old. I wish we can do that for anti-aging kind of research, but I don't think it's going to be to that same level to the earlier stage. I think it's going to be lesser, but at least you have some preventive measures.
Okay, thank you. Okay, we move to the next question from Sabrina, still from Faculty of Medicine, Universitas Indonesia, to Professor Hamid. In your opinion, would it be better to consume calcium, vitamin K, vitamin D supplementation from early adolescence, especially among women, to prevent insufficiency during pregnancy? If it's necessary, how is the recommended dosage of the supplementation?
Well, I don't have any supplement company. I may answer differently if I have the company. So I will answer as a nutritionist. I think the first step is to get it from natural food. If you are eating well, if you consume milk, if you consume ikan bilis, ikan bilis, anchovies, okay, tempeh, okay, and then if like vitamin D can be obtained from milk. So if you have a healthy, balanced diet, I don't think there is really a need for you to go to supplementation. That is the first message. However, if you feel that you cannot achieve the optimum dietary strategies due to your busy work or etc., then yeah, it is good to get it from supplement. And I would not just go to these 3-4 supplements, probably multivitamins with low dose of multivitamins or certain vitamins that you think you may get benefit from, especially if you are planning to get pregnant, because I think pre-pregnancy nutrition is very, very important, not only during pregnancy, but before pregnancy. So the reproductive age woman should eat well as a process, as a strategy of preparation for healthy pregnancy. But if cannot be achieved, then supplementation could be another options. Thank you. Yeah.
Including folic acid.
Yeah.
Folic acid.
Yes, that's very important. I guess it's,
Yes.
I don't know if that's recommended by the government here, Ministry of Health here, but it certainly is in New Zealand. Yes.
I think it's the WHO recommend 4 months before pregnancy, you should have folic acid. But if you have an accidental child, then that is a bad news because you are not really prepared for the folic acid. That's why lifelong healthy nutrition is important.
Absolutely.
Okay, great. Maybe another question from the floor.
Assalamualaikum warahmatullahi wabarakatuh. Good morning to the lecturers. My name is Hafsa. I'm from Magister Program of Nutrition. My question is for Professor Jill. In your presentation earlier, the combination of vitamin C and thiamine for critically ill patients seems to have excellent result for decreasing mortality rate for critically ill patient. My question is, is it can be applied for all patients, or is there any contraindication like patients with kidney failure or hypertension? And my second question is, in some paper also mentioned that thiamine alone is enough to give best result for critically ill patients without combination of vitamin C. So what do you think about this? Thank you very much.
Yes, thank you very much. Well, we're waiting for the last study that I mentioned that's currently underway in Austria, that hopefully will give an answer to your question. At the moment, there were indications that the combination, the HAT combination of hydrocortisone, ascorbic acid, and thiamine has some benefit in reducing mortality. It was a small study. Some further studies have confirmed it. Others raised questions. So it's still not clear, which is why most recommendations possibly dropping the hydrocortisone, at least for the time being, and focusing on investigating the higher dose of thiamine, which hopefully the study in Austria will show us. But I think the results are not going to be available until next year. There was a second part?
The second is some papers also mention that thiamine alone is enough to give best result for decreasing mortality rate without a combination.
Yes, yeah. I would probably support that view at the moment, to concentrate on thiamine. It's been demonstrated, as I said earlier, to be quite safe to use at high doses. It's not that expensive. And so until we have further data from some of these larger and better formulated trial protocols, then I would just go with the thiamine.
Thank you very much, Prof.
Okay, thank you, Professor Gill. So maybe the evidence is stronger with thiamine than the combination of thiamine and vitamin C, but we still need further data.
We do, and yes, we need. I don't want to criticize these very talented investigators, but we know that vitamin C, for example, is quickly oxidized when it's in the air. And I just fear that some of the conduct of these studies may have been thinking they were following the protocol, but you know what happens in a busy ward or in a busy intensive care unit when you're treating a patient. If you've got a PN bag, for example, with vitamin C that you've added a lot of, and it's not used immediately or exposed to air, then you're not actually giving vitamin C as such. And I suspect that wasn't controlled. It's never mentioned in these papers, but I think that's a confounding factor that we need to look at. And you can do that by making sure that when you're carrying out the study, you're protecting your supplement from air and light in particular, so that you can be sure that you're giving the dose that you wanted to give. But that's a criticism I know has happened in some other trials. So that's but it's very easy for me as an academic to criticize, but I know that if you're in a busy intensive care unit, then worrying about a supplement is possibly quite low on your list compared to saving the life of the patient and all the other essential tasks that have to be carried out. So it's not easy, but it's a great challenge for anyone who's interested.
Maybe there's another question about the contraindication for vitamin B1, thiamine, that you have recommended that there's a potential benefit of thiamine in the critical ill, but what is the contraindication when we should not give thiamine to our patients?
I'm not really aware of any contraindication. No, I mean, you would think, well, what about maybe, I haven't seen any adverse reactions reported, and there was some benefit in acute kidney failure. So it doesn't, any kidney problem doesn't seem to be an indication. I can't see any reason why any liver failure problems could affect it. It's possible, I suppose, because so much gets metabolized through the liver that it may be that you've got serious liver damage. You should be more cautious, but otherwise I can't see any contraindications.
Okay, thank you, Professor Gill. Maybe there's still 15 minutes left, so we still have a time for discussion. Maybe another question from the floor. Is there any other question online? Okay. Another question from the floor? Okay, I don't think there's any other question. So thank you, Professor Gill and Professor Hamid. Now we have come to the end of the guest lecture. I would like to deliver the conclusion from what the speakers have presented. So from the first presentation, an interdisciplinary team for weight management consists of physician, registered dietitian, the exercise specialist, the behavioral therapists, and the nurses. And we can help the patients with small steps and feasible goals to achieve lifestyle change and successful weight loss. From the second presentation, ICU patients exhibit low micronutrient blood levels, and high dose supplementation of micronutrients is not indicated and potentially harmful for the critically ill. But there are potential benefits in supplementing vitamins to the patients with deficiency. But further research is still needed on this topic. The third presentation, bone minerals, vitamin D3 and vitamin K2 and are important to maintain bone mass and also essential amino acids for growth in children. Vitamin K2 supports bone formation and prevents calcium deposition in the arteries, but there is still more research to be done in this topic also. So I would like to say thank you again to all speakers for the informative and interesting presentation, and to all the participants for the active participation. I will close my session, and the information about our next agenda will be delivered by MC. Thank you.
Yes, thank you so much, Dr. Steffi, speakers, and also all participants. We sure all find today's discussion a very interactive learning process that is informative and also useful for us. Let's hear it one more time for the speakers, moderator, and all of the participants. Let's applause for them one more time. Okay, honorable ladies and gentlemen, thank you for your participation in today's guest lecture. Before you leave the room, kindly fill out the presence form, and you can find the link on the screen in front of you. And for those who joined us via live stream, Zoom or YouTube, you should also fill in this presence form in the Google form. Please type it in your browser, bit.ly/attendance evaluation 31 July 23. And ladies and gentlemen, on behalf of the committees, we are grateful to have all of you here, and we beg your pardon for any mistakes that we have made along this event. And this is the last of our agenda. Lastly, my name is Fadila Sudeandra, signing out as today's Master of Ceremony. It is our pleasure to have all of you here today. See you at the next event. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, thank you.
Thank you very much.
For all participants who are wondering for the certificates, the e-certificates will be given to all of you via email. Please fill in this presence form so we get your informations and we can send the certificate to your emails. Thank you.